Hospital acquisition of physician practices has become a dominant trend in American medicine, with potential implications for the quality and cost of care. New antitrust guidelines issued by the Federal Trade Commission and the Department of Justice could affect how regulators approach these transactions. I'm Stephen Morrissey, managing editor of the New England Journal of Medicine, and I'm talking with Dhruv Khullar, an assistant professor of medicine and of population health sciences at Weill Cornell Medicine. Dr. Khullar has co-authored a perspective article about vertical integration in healthcare. Dr. Khullar, what's known about hospital acquisitions of physician practices in the United States? How has the number of physicians who are employed by a hospital changed, say, over the past decade?
Vertical integration really refers to when two entities that traditionally operate at different stages of production, they combine into a single entity. And so you might think about an automobile company that produces the relevant parts for the automobile, and they also make the car and they sell the car. In healthcare, there's been an enormous trend towards hospitals acquiring physician practices that has really accelerated over the past decade. And so when we think about this, we've seen basically the share of physician practices that are owned by hospitals more than doubled between 2012 and 2018, such that nearly a third of all practices are now owned by hospitals. And that number has probably gone up over the past few years. We know that during the COVID-19 pandemic, for instance, thousands of more practices were acquired and tens of thousands of additional physicians, they became hospital employees. And so really the motivating insight for this perspective was this idea that as hospital-owned practices and hospital-employed physicians become the dominant way in which medical care is delivered in the United States, we really need to understand the quality, the cost, and the outcomes that are associated with these arrangements.
So what are the incentives in the healthcare system or other factors that have contributed to this trend?
There are many factors that have contributed to a trend towards increasing hospital acquisition of physician practices. In particular, there are a number of payment policies that have accelerated this trend. And so Medicare and other insurers, they pay a higher rate to hospital outpatient departments than they do to independent physician offices. And so some estimates have put the cost for common oncologic or cardiac services that are delivered by a hospital-owned practice as 40 to 50% higher than the cost or the price that's delivered to independent practices. There have been some other payment programs like the 340B program, through which hospitals can purchase outpatient cancer drugs at lower rates and administer them at a higher profit. And that has encouraged the acquisition of oncology practices. And finally, I'll point to value-based payment programs. Many of these payment programs can introduce substantial administrative burdens in terms of collecting and reporting data. And so small and independent practices may sometimes feel that they have little choice but to merge with a larger entity.
Are there potential benefits of this type of consolidation for either physicians or patients?
Certainly, there are arguments to be made in either direction. And one of the motivating factors for this perspective is that we need more evidence really to guide policy on this issue, because theory can point us in both directions. So there are reasons to believe that vertical integration could be good for patients and for clinicians, and there are reasons to believe that it could be less good. For instance, on the positive side, you could envision that when hospitals are in closer affiliation with physician practices, that can enhance care coordination across care settings. It can improve information exchange. It can result in economies of scale. There may be an infusion of capital if the hospital is better resourced than the practice, and that allows the practice to do things that it otherwise would not have been able to do. There are also some less good aspects of hospital acquisitions in theory. For instance, the evidence that we have so far suggests that prices that are paid for services tend to go up for several reasons. The merged entity often has greater negotiating leverage relative to insurers, and so can often extract higher prices. We talked about the facility fees that are paid to services that are delivered in hospital outpatient departments, even if it's the same service that would otherwise have been delivered in an independent practice. And there's also some concern that large health systems could potentially divert resources away from important but less profitable services away to more lucrative ones.
You say in your perspective article that hospital acquisitions of physician practices have gone largely unreviewed by government agencies such as the FTC and the DOJ. Why is that the case?
That's true. So the Federal Trade Commission, the FTC, and the DOJ, the Department of Justice, they have traditionally been the agencies that address consolidation in healthcare and in other parts of the economy. They haven't taken a very active role in these types of acquisitions for several reasons, partly because they have limited resources to devote to antitrust activity, partly because many of these transactions fall below the threshold, the financial threshold at which they must be reported to the government. And so a lot of these transactions, while each individual transaction may be small, their aggregate impact can actually be quite large. And so the FTC and the DOJ released new guidelines at the end of last year that outline a number of principles. They may lead them to take a more assertive role in curbing certain types of anti-competitive consolidation.
So, in what ways are these new guidelines expected to affect enforcement considerations and activities?
There are a number of ways in which these guidelines might inform the way that the FTC and the DOJ go about conducting antitrust enforcement in the United States. And we outline a number of those in our perspective. For the hospital acquisitions of physician practices that are in question, we really want to focus on three big areas that we think we need greater evidence so that these guidelines and these agencies have the information that they need to make important regulatory decisions. The first is around how the effects of vertical integration might vary by the form that the resulting health system takes. And so we talk about how a small rural hospital that acquires the area's lone primary care practice, how the effects of that type of acquisition might differ substantially from a large academic medical center that acquires yet another profitable subspecialty practice. And so there are some guidelines that the FTC and the DOJ have released talking about whether an acquisition increases or decreases competition in an already concentrated market, whether it might prevent the entry of new competitors into that market, and whether it might reinforce the dominant position of an already dominant player in an area. The second big question that we like to focus on is around how practice acquisitions affect clinicians. And so in the past, antitrust agencies have generally challenged mergers if they thought that that merger would increase the prices that consumers paid. But now they're starting to take a much more expansive view of such acquisitions. So one of the guidelines explicitly focuses on whether a merger could lessen competition for workers, and it might result in lower wages or poorer workplace conditions. And so we feel that there needs to be a lot more evidence to understand how vertical integration either improves or does not improve the experience of caring for patients. And finally, we're interested in which patients benefit and which patients might be harmed by these types of acquisitions. And we focus on two groups in our perspective. The first is medically complex patients, those with multiple clinical conditions and frequent interactions with the healthcare system, who might be particularly affected by any changes in care protocols or referral patterns that are instantiated by hospital acquisitions. And the second is lower income patients who are often cared for by less well-resourced practices. And there's a lot of evidence that we need to understand, are these types of practices acquired or are they preferentially avoided when hospitals go about acquiring practices? And what are the effects not only for patients in those acquired practices, but also for patients at non-acquired practices in the area?
Finally, do you expect that this trend toward vertical integration is going to continue, or do you think that these guidelines or other forces are going to cause a change in direction?
I think for the foreseeable future, it seems that this trend will continue. Hospital acquisitions of physician practices have increased substantially over the past decade. And that's not the only form of acquisition. There's also been activity in terms of insurer acquisitions of practices, private equity firms that are acquiring practices. So I think that this is a really dominant trend in American healthcare. And I think we need more information to understand who benefits, who might be harmed by such activity, and ultimately how we should go about resolving the tension between the potential benefits of greater integration and coordination and the potential challenges in terms of anti-competitive activity.
Thank you, Dr. Khullar.